sharing of best practices between the medical groups, and that is we're going to talk about a broader approach to community collaboration. The Sierra Health not only hosts the Right Care University Best Practices, but they also host the Healthy Sacramento Coalition. And I'm very happy that we have many of the Healthy Sacramento Coalition members with us. And today we're going to hear from a leader within the Healthy Sacramento Coalition, Deborah Odo-Kent, about a more primary prevention element than what Right Care normally focuses on, which is secondary prevention and sharing of best practices across the health system. So this is a more community collaborative meeting than our norm. And we're also going to have Professor Hector Rodriguez and some of our colleagues from UC Davis talking with us about 1 year out, a research agenda. I don't want to steal Professor Rodriguez's thunder, but 1 year ago, he took us through a priority setting process. We've had a lot of changes in the faces in the room, so we'll revisit that today. With that, I think I'd like to hand it to Dr. Arevalo for a couple of opening remarks and going around the room and introducing ourselves.
As usual, I got a cup of food in my mouth. Pretty often. So thank you, Hattie. Well, we're really excited to continue our monthly meetings on Right Care and to talk about what we're doing locally with our collaboration. Because we talked in the past, this is really about collaboration with all of you and with our partners, organizations, health organizations in this community. And it's about reaching out and sharing best practices. And there's a new demonstration today about some of the opportunities. So we're really excited to have this particular agenda and program for you. And we will be making some announcements, we hope soon, about Right Care and where we're moving, but we're still developing those as we speak. Again, this is about your participation because it's really about what you're going to do as you go out to your everyday life, that you learn from Right Care and what you can take and bring back to us as well. So I'll leave it at that for now, and I wanted to start the introductions, but let's start with Alan Erdl, who I'll let himself introduce himself, but Alan's working with us more closely right now, and we hope to work with him even more closely in the future.
I'm Alan Erdl. I'm the Chief Medical Officer of Mercy Medical Group here in Sacramento.
You all know me. I'm Hattie Hanley, Right Care Initiative.
I'm Debbie Odo-Kent with the Health Education Council. Jessica Junius de Ravna, the California Department of Public Health.
Mary Ferguson, Chief Medical Officer, Health Services Advisory Group.
Jim Ellsworth, Capital Health Network, Consortium of Community Health Centers.
Mike McCabe, United Healthcare.
James Palmieri, California North State University College of Pharmacy.
Hector Rodriguez, UC Berkeley School of Public Health.
Jen Spell, Associate Professor at UC Davis School of Nursing.
Even in Rich United Here Health, we're a health plan for union hospitality workers across the country.
Jim Bates, Chronic Disease Control Branch, California Department of Public Health.
Hi, Jim Corcus. I'm the Northern California Medical Director for United Healthcare.
Dina Jacinto. I'm with AbbVie. I work in the Population Health Division.
Martha Garrity, I work for HealthNet, representing Northern California for health education programs.
I'm Joan Werbeling, recently retired UCD nurse specialist for diabetes, and I'm now Vice Chair of the California Health Collaborative.
Jerry Jeffy, California Chronic Care Coalition.
Bill Remack, California Hepatitis C Task Force, and California Chronic Care Coalition.
I'm Gil Simon. I'm the medical director of Sac Family Medical Centers.
I'm Darrell Fleming, Sacramento Family Medical Center.
Liz Helms, California Chronic Care Coalition.
Leonard Fry, first visitor here, first visit here, and I'm a small businessman in several small businesses, and I'm here seeking partners to establish a collaboration, a accountable care community.
Jody Beverly, Blue Shoulder, California.
Anita Rivero with California Rural Legal Assistance Foundation, Director of Community Advocacy Special Projects, and we open, Health Open, Farm Workers Health Clinic in Knights Landing, Yolo County.
Jill Joseph, UC Davis, Video School of Nursing.
Swati Ostray, Medical Director for Northern California Aetna.
Krista Robinson, Health Conditions Management at North Valley Kaiser.
David Matsamura with Nova Nordisk.
Diane Baker, School of Nursing in Sac State.
Hi everyone, Rachel Rios, Latin Housing Center. Ellen Montgomery, Drexel University Public Health Consultant.
I'm Diane Littlefield with Sierra Health Foundation.
Hello, I'm Chris Wood from Dignity Health.
Dan Darby with Barrington, Ohio.
John Forrester, Quality Improvement Leadership Position.
Brian Barnes, UC Berkeley School of Public Health, and Grace Presbyterian Church.
I'm Debbie Nixon, I'm in Health Services Advisory.
Does everybody introduce themselves now? With that, I would like to invite Hector Rodriguez to come join us at the podium. In the spirit of collaboration, the UC Berkeley School of Public Health and the UC Davis School of Nursing are going to speak with us today about opportunities to collaborate on improving patient outcomes with or without funding. I will have Hector introduce Dean Jill Joseph and Janice Bell from the School of Nursing. And I just want to say that Hector has been an amazing piece of the backbone of the Right Care Initiative, quietly in the background, always helping us move forward. So last year, exactly 1 year ago, he took us through a priority setting process, which helped us to identify that the health systems of Sacramento want to prioritize educating the highest risk patients and their families about not only preventing the hard events of heart attacks, strokes, and diabetic complications such as amputations and blindness, but also the need when an event does occur, not to transport themselves directly to a health facility, but the need to call 911 and transport via emergency medical services so that they can get the patients to the appropriate facilities that are ready for that patient and have their teams ready to go. Because what we know is that time is brain, time is heart, and it's important that that EMS system be communicating with the emergency receivers so that when the patient does arrive, they have the best odds of having a good outcome. I will let Hector talk further about those priorities and just say that the wealth of knowledge that he brings from his training at Harvard and UCLA has been an amazing gift to the community of Sacramento, and I so appreciate that he does this completely as volunteer work. So with that, Hector, thank you.
Thanks so much.
I know many of you here were here a year ago during our priority setting process, but I wanted to just bring everybody onto the same page and discuss, because things may have shifted in your thinking. So today you have clickers, or you should have gotten one as you registered and got your name tag. And I just wanted to do a quick check of the distribution of organizations. Which sectors do we actually have involved in the room today? So if you could just click on your response, then we could see who the dominant, whether we have representation from everybody across the sectors that we need to do multi-sector collaboration. Nice, I see it's stable around 20. Okay, there we go. Okay, we'll be closing polling right now. So it looks like the biggest is health plans and payers, followed by patient and consumer organizations, followed by universities and research, and then an equal representation of physician organizations, pharmaceutical organization, and others. So we do have a nice mix in the room today, and I think that will really bode well for our discussion, which involves everybody. Really, it's not just about the delivery systems and their actions to improve cardiovascular disease outcomes. It's really our community here. I wanted to review the collaborative priorities we identified last year, and then Janice and I will pinch hit. I'll be describing this regional stroke idea, multi-sector collaborative, and Janice will move on with hypertension control using IT. Patient-centered IT, both in clinical and non-clinical settings. So embedded care team members as well as care team members that are not co-located, and strategies and testing those approaches to CVD risk reduction. And then finally, as part of this, the point that we're trying to make here in showcasing these potential multi-sector collaborative opportunities is really to get you all to weigh in on, is this the right direction for the Sacramento region? Is there something different that we should think about? And what are our commitments? What can we, as part of our organizations, bring to the table to move the needle here? So just to recap, the 3 areas that we identified last year, and this was a voting process. Many of you or your representatives were here for that meeting, but they really were 3 synergistic ideas. That could involve multiple stakeholders here at the table, not just the delivery systems, but the payers can be involved, consultants can be involved, the QIO, HSAC can be involved, academia can be involved. And the first one was really education of the high-risk patients and families of signs and symptoms of stroke and calling 911 when these symptoms are identified. I think Hattie underscored many of the delays that happen here as part of stroke identification and transport. But clearly, previous research has demonstrated that the largest lag really is from identification and calling 911, or the person getting to care. So it's really a patient and family-driven phenomenon. That's where the biggest lag is. And I think last year we identified this as a priority because I think it's the greatest opportunity for improvement, but it's also the hardest one. Educating patient and families. Previous research has shown that even when patients and families are educated on signs and symptoms of stroke, they don't necessarily know to call 911, and when push comes to shove, that information is sometimes lost or it's not retained. And so I think part of our work here is finding solutions that involve not only one part of our system, but all parts of the system can support this. And what I mean specifically in this realm of high-risk patient education and families is there could be public awareness campaigns in tandem with provider education and patient education. Payers could begin to think about paying for different types of education for high-risk patients, etc. Only when we have everybody at the table. We've seen over and over again that pilot studies done as a one-off tend to fail or have limited success and they dissipate over time. And if we're going to make something transformational here in terms of impact, we're going to have to all work together. Second area for priority is intensification of efforts to control cardiovascular disease risks. This includes blood pressure, cholesterol as primary clinical measures. And really doing more proactive outreach by clinical staff, using care team members to do this, using technology in innovative ways to promote care coordination. And Janice is going to speak more specifically about this idea along with home blood pressure monitoring, which was the third area of priority we identified. So as you can see, these are kind of synergistic ideas. They all have the potential to involve multi-stakeholders, and that's why we're revisiting these to get your feedback on how we should move forward collaboratively. I just wanted to underscore why we should be in this together. We recently, with Health Service Advisory Group and the Right Care Initiative, looked at the morbidity and mortality from heart disease and stroke of California average per 100,000 population compared to the greater Sacramento region counties. And we could see we have a lot of opportunities for improvement. In fact, of the 7 counties represented here, starting from Sacramento, have higher heart disease mortality than the rest of the state. And this is age and sex-adjusted information from 2007 to 2011. So we do have pockets of hotspots in specific counties in this region that we should be attentive to. And this should hopefully motivate us to work together to address this problem. There have been many successful national campaigns at trying to achieve the first aim that we identified, which is reducing time to treatment for stroke. And that the national campaign that the Stroke Association has promoted is FAST, which is identification of facial drooping, arm weakness, speech difficulty, and the importance of time in terms of preventing brain damage. And so I think there are models we can actually adopt and promote as part of our effort. And there's already existing programs that we can use and leverage as part of this effort. And just to go back to the evidence that we reviewed last time on this issue of stroke education, it was clear that there's been attempts to do this across the country and internationally to improve time to treatment for stroke. But we know that there's been limited impact on behavior, and largely because these campaigns have been conducted in narrow ways, not a community multi-sector approach like we have the opportunity to do here. We also know that patients, if they're given counseling and education about stroke risks, patients that are high risk, for example in the emergency room, who have elevated hypertension, they do have better skills and knowledge with respect to stroke, but really there hasn't been a lot of large-scale studies looking at the effect of education, so they're suggestive of effects here. And Janice, if you wanted to review the home blood pressure monitoring evidence here, great.
Thanks, everybody.
So Hector had asked me to focus on this idea of home blood pressure monitoring. And looking at the literature, it's pretty clear that this is possibly a good area for a nice multi-sector collaboration. Most of the studies that have been done in this area so far are relatively small, and there are some contradictory findings in that literature as well, and there have been calls for some large-scale, really well-controlled trials. This approach is also shown to be superior to clinical monitoring for both diagnosing high blood pressure and then our hypertension, and then also at predicting prognosis. And it's been used in some studies for risk stratification. I found this report online, this Telehome Care and Remote Monitoring report, which really points to the importance of what we have here in this room. So this idea that the results are promising, that technology is going to be needed, and that we're going to need a lot of different sectors to come together to really pull something off in this area. The team that I work with at University of California, Davis has been working hard on this problem we call the Care Coordination Challenge. And this diagram here is pretty typical of what patients go through. So the patient is typically at the middle of trying to coordinate care between inpatient and outpatient, between primary care and between specialists, and all these different touch points in the community. And we know that some patients do this better than other patients for a variety of reasons. And the solution that we've come up with to try to address this focuses on nurse-led care coordination, where nurses lead teams, manage large panels of patients, maybe with community health workers who help in a health coaching role, where technology is front and center in helping to do this work, and where there is collaboration with providers and then across the community as well. So some of the guiding principles that we've adopted are that it's really got to be patient-centered, that it has to be evidence-based so that there are protocols to guide this care coordination as well, that technology is a big part of it, that the outcomes are evidence-based, and then that we share the outcomes back with the patients as well as the providers and everyone involved. So we've been working with a technology partner called Teatros out of San Francisco. We chose this technology partner after a pretty detailed environmental scan and finding that there aren't a lot of vendors out there who are doing this kind of work and providing the infrastructure to enable care coordination adequately. The features of this one are that it's scalable, so you can really ramp up to very large panels. It can be adapted to many different conditions, and we currently have work going on in cancer care and in palliative care. It's cloud-based, it's HIPAA compliant, it's a social network style software, so it's like Facebook for patients. And patients have this care pod where they choose not only their providers, but which family members they want to be able to see their information. And then there are other providers that can be invited as well, so anyone on the care team can be involved. Other nice features of this are that the patients can generate data. So this is where the home blood pressure monitoring could come in. So patients could be feeding this data back to the care team through this technology solution. The nurses can conduct assessments, and then they can feed that information back to the patients as well. There's a shared care plan, there's appointment reminders, medication management. There's a library where patient education materials can be stored and family members can access them. And then there's secure messaging and video chat. So if you need a referral with a social worker, for example, you wouldn't necessarily have to come in. Now, I can imagine that a lot of you in this room are saying, well, who would pay for that? So one of the things we might have to do as a community is to decide how do we pay for these kinds of services that maybe aren't the typical in-the-office visit. So I'm going to leave it at that and let Hector talk a little more about these multi-sector collaboration ideas and can answer any questions about the projects that we have ongoing now.
Thank you. Thanks, Janice. So I just wanted to underscore, a lot of the times we talk about multi-sector collaboration, and it's really about the provider organizations and everything that they're doing. And I think I'd like us to take a pause and think about these two ideas. One is, reducing time to treatment for stroke through patient and family education and those supports, and also sort of the care coordination issue with respect to CVD risk management. And here are some ideas that Janice and I have talked about in terms of potential roles for different sectors as part of this work. So, clearly the frontline clinicians are involved in practice change and implementing education or care coordination. The hospitals and health systems, at the, discharge coordination may support these initiatives as well. In terms of health plans, to support the real-time monitoring of these high-risk patients, so oftentimes health plans and payers can play a role in that, or also pay for care coordination. There's some pilots around the state and country that are actually paying for a per-use care coordination fee to support adoption of these programs. Technical assistance organizations like HSAG also have a role here. As part of their scope of work, they can support a multi-sector proposal for quality improvement, frontline assistance. Government agencies, you all have a role in terms of coordinating across the complex web of local, regional, and state policies. And universities, we can play a role in helping monitor and evaluate the progress that you're making as part of these initiatives. And then, of course, other industry partners may have roles as well. So hopefully we've gotten you to think about what potentially your organization might contribute to something multi-sector, regional collaborative in this area. So I'm just doing a temperature check here. My organization would be interested in contributing to a regional multi-sector campaign to improve CVD outcomes. If you can all vote, and if you don't have the authority to vote on your organization, it's okay, we won't tell on you. Or you could say, but I need to think about it, or some other option. This is just to get your ideas flowing. All right, we have additional responses here. So we have everybody, the nice thing, and this is why I love coming to these sessions, that you guys are can-do people. And we have 60% saying yes, definitely, and you have some ideas about how your organization can contribute. 21% yes, but let me think about it. Yes, maybe I need more details. Maybe one person said no. So we'll find you. So I'd like to entertain sharing. For those of you who said yes and I have some ideas, this is the time we'd love to hear your ideas. Anybody willing? Perfect. Juanita.
Well, at the very beginning, when we used the clicker, the word community was never in any of those. So maybe other can become community, and then split other to 10.
In terms of stakeholder representation?
Yes.
Great, good suggestion.
Yes, and this is a great beginning that there's a sprinkle of us from the community here. Not enough, though.
What do you, I guess in terms of your role, what could your organization, for example, bring to some of these ideas?
I think what goes out in the fields, for example, 911 is a great idea, but we need to get the word out there because of the cost. A lot of times it's because of money that people don't call 911.
They think they're going to be on the hook for the bill.
Yes, for the ambulance. And so that needs to be, corrected out there and big time.
So your organization can help with the education in terms of
the outreach to the community, wider community. The other one is that not enough in terms of emergency. 3 weeks ago, a farm worker died from heat stroke with a heart condition out between Esparto and Woodman. The helicopter got there not in time. He died on the way. I think a better system, for workers that are out there, not just farm workers, but all the workers that are out there that are far from,
Yeah, those are special cases that definitely need a targeted approach there. Any other ideas?
So labor unions need to be included at the table.
Excellent points. Any other people from delivery systems? We have 2 minutes, so I'd like to get some energy out. If you have a bubbling idea, we'd love to hear your idea.
Jim Ellsworth from the Capital Health Network Community Clinics.
Hi, Hector. Thanks for dragging me into it. The primary care system needs to coordinate both with the hospitals, health plans, and the community to be more proactive in primary medical and behavioral health services. That's something that we are looking at building over the course of the next couple of years in a variety of ways.
Right. So at behavioral risk factors as they relate to CVD outcomes, that could be a focus?
Absolutely. Ultimately, we need to have better tool sets available to primary care providers. We've now all implemented EMRs, which will allow us to do better medicine and create more patient-centric services and have a better ability to capture the data related to our primary care services. Now we need to reach out just a little further and start coordinating with the hospitals so that we can be proactive for high utilizers and high-risk people. We can, in fact, be proactive in our identification of people that are at risk of cardiovascular events or stroke events. We still need to develop those tools, and we need to develop the collaborations, not only with the hospital systems, but also with the community, if we're going to get ahead of it, and instead of being reactive to a stroke or a heart attack, prevent it. And then we'll
Excellent. Well, this is great. We're going to have to move on, unfortunately, but I do want to get another temperature read here. Because we mentioned earlier that many of you are new this year, and that I'd like to get a barometer of where your interest is. Is it really in improving stroke education? If we had to focus on one multi-sector collaborative area, I just wanted to get a temperature check. Is it really about the stroke? Is it about CVD risks through through teams and patient-centered technology like Janice presented? Is a hybrid of sort of both concepts? Some other idea, so I think, Jim, your idea about behavioral health would probably fit into a different idea. Or D, you have a totally different, or D is you have a different idea, and E is no opinion. And then we'll move on to the next speakers. Great, so you guys are hybrids here. Most of you guys want to do both activities. They're synergistic in a lot of ways. We're going to have some great presentations next relevant to these areas and these priorities. So I'd like you to continue to percolate these ideas of multi-sector partnership and how the information from Dr. Deibara Nunez and Deborah Oda Kent, how they sort of lend insight into potential of working together in the Sacramento region. So thanks so much. I wanted to just put up here, you can contact Janice or me by email. We're going to have these slides up on the website so you can also access them. Thanks so much.
Thank you very much, Dr. Rodriguez and Dr. Bell. That was really excellent. And it's good challenges that we're going to move forward with information. But what I wanted to do now, I have the distinct pleasure of introducing Jessica Nunez de Ibarra. And I have actually known Jessica since she was a medical student. I hope she admits that.
Yes.
And she was here at UC Davis, and we worked together even as she was just an outstanding medical student. As you can see by her brief CV and the presentation she's going to make. And I've also had the distinct pleasure of working with her as the current president of the Sacramento Latino Medical Association, so we work very closely together. And so Jessica has done a tremendous job with Salma in the years she's been the president. And I want to reach out and congratulate her on that. So, but what Jessica is going to, she's been very active in public health. She's a public health officer, educated in public health, and has now taken on a major role in the Department of Public Health being the really director of a program that she's going to talk to us about, the California Wellness Plan, which is really the California Department of Public Health getting together to address how we as a community, and particularly through the auspices of public health and the Department of Public Health, can work together collaboratively to improve the health of our whole state. So this is not a small subject. So I'm really excited, first of all, what she's going to present to us, and secondly, to congratulate her on her new title and her new role that she started in July. So I'll let her do the rest. Thank you.
And while she gets settled in, I'll just say that Jessica brings wonderful new energy to the California Department of Public Health. She's been a fantastic collaborator for the Right Care Initiative since the day she walked in the door. And we are so thrilled that she's leading up chronic disease now at the Department of Public Health. And we'll be working much more closely together in the future.
Thank you all very much. It's a privilege to be here. I wanted to present quickly. I only have 20 minutes and we'll try to stick to that because today's time together is really critical. I really appreciate the overview and dedication to the work done this past year and the researchers that have come and through the goodness of their own heart and commitment to our work. Their presentation today was really outstanding and very much aligns with our work at the California Department of Public Health. But in my time here, as said before, we've all interfaced a little bit, and I'm wanting today to share with you some exciting news. I'd like to provide to you, for those that have never heard of the Let's Get Healthy California Task Force report that was developed in 2012, a little background and how that fits into our work on the California Wellness Plan, as well as some new opportunities that the agency secretary is proposing. Again, we in California have dealt with incredible fiscal difficulties. In the height of the recession, the new Governor Brown, when he came on board, decided to issue an executive order. He asked our agency secretary at the Department of Health and Human Services for the state of California to demonstrate to the people of California with a task force of thought leaders like yourself how we would minimize fiscal burden into the near future, specifically in the area of health expenditures for the state. He issued an order and asked her to develop a 10-year plan for where we would not only lower costs, but what about value? What about for the care that we're all given? How can we improve the quality? And also at the same time, educating people. It's all the tenets that this group is about. And also looking at where the disparities lie. Again, Secretary Dooley took that to heart and developed a mantra, which is, what will it take for California to be the healthiest state in the nation? She brought together her task force of very expert leaders, and they came up with this framework and a report that was issued in December of 2012. If you look at the very top, you'll see the term the triple aim, and that refers to value in healthcare, where for our investment in healthcare, we should be offered and be aiming for better health, for the quality of that care, and to get it for the best cost, or the lowest cost in this case. We then, at the top of the circle, what you'll see is where in health are we referring. And we in health, and all the partners to the agency secretary, agreed it was across the lifespan. That for pointing to a particular period of time is not fair in the context of all the things that impact health. So we wanted to make sure we looked at the beginning of life, healthy beginnings in that left corner. Then looking at what we'll be doing to prevent chronic disease at that top. And at the very end, making sure we do the best at end of life. Obviously, there are a lot of pathways to health. In the center of the circle, what you see are 3 areas of focus that were decided in terms of the health system to focus, looking at redesigning the health system, looking at the environment overall, primary prevention. What are we doing collectively to create healthy communities? And then finally, looking at cost. At the very bottom frame, you have the foundation for our work, which is eliminating disparities and health equity. There is the full report online, and I've put the link there. And again, this will be shared with you, and I'm going through very quickly because, again, this is just an overview. But I'm happy to share with you that I was tasked back in October of 2012 to develop a chronic disease prevention and health promotion plan. And I'll tell you, in developing it and in reviewing the results of the Let's Get Healthy Task Force report, it was clear to me that the majority of place that the priorities of the report focused was on chronic disease prevention. And I share that with you because that's where the opportunity is, the work, and for all the reasons you are all well aware. So we incorporated Let's Get Healthy California Task Force priorities, which look at long-term outcomes And those are the framework for our plan. We obviously, and I have a copy with me. It is quite large. And I don't know, how many of you have glanced at this at all? Okay, a handful of you. The nice thing is the center of the plan, this is kind of like a telephone book. This is not a compendium on everything about chronic disease. What you'll see, and I'll go through it in a moment, is that things are organized in an outline form. So you'll see the objective we have, whether it's short, intermediate, long-term, and the data source for where we receive that metric, because each is a request to do better. So for instance, our intermediate objective, 2.6.1 intermediate, I'll tell you what that means. The point is each objective has a number. Says that by 2018, increase the number of adults who have been screened for high blood pressure within the previous 2 years from 91% in 2008 to 93%. How many of you have ever heard of that metric before? How many of you could say that you know where your organization ranks in terms of that measure? Okay. These kinds of measures are the measures of the future, and I'm happy to share with you that we have those kinds of metrics in here. And there's a data source listed for where you can find information about those kinds of measures. The bottom line is we're trying to move to a place in this work to be able to tell people it's not about doing X, it's about doing X so that we can get to Y. In other words, it matters now. It matters, is our intervention effective? If not, can we regroup and try again? Because at the end of the day, as you're all well aware, these are people and lives, and we can do better. We've also incorporated, and I'm just telling you a few important buzzwords because if, as you know, my job is to kind of get people in the know about this, and I'm really hopeful that in your own organizations, as you share these elements, that this is helpful to you as you communicate with folks about some of the innovations we're trying. But healthy community indicators are beyond what kinds of things we think about in the healthcare system. So for instance, a healthy community indicator may even look, and it's listed in the report, where are we on the reading level of third graders in the state of California? Because guess what? Where kids are in their educational attainment, and are they reaching those marks, impacts the health of the population, and it's predictive. These are the kinds of things we think about when we look at a healthy community indicator. So they're also incorporated in this plan. All right, so our aims for the plan in the end were to understand that chronic disease has multiple factors. You'll get a sense of it when you review the kinds of things in each area. We also wanted to share with you what the department and other people in state government are doing around these areas. Specifically, who has the data for the information that we're interested in. We also thought it would be a roadmap for collaboration, working together. And then again, my aim specifically is, can we do better and show it? So the goals have been organized. Again, the frame is equity in health and wellness. We're looking at that primary prevention, healthy communities, the environment we live in. If you go to goal area 1, the objective I just described to you is out of goal 2, which is optimal health systems linked with community prevention. Kind of speaks to the issue that was described today about more of a linkage in blood pressure monitoring from home. And then number 3 is accessible and usable health information. We can't go far without the data to work on our interventions in a mindful way. And then finally, this last goal was requested by our stakeholders and partners who said, well, it's good and well you want to do goal 1 through 3. That's very ambitious, Jessica, but how are you going to pay for it? So the 4th one is looking at, well, how do we sustain this kind of prevention. So you can find an electronic version of this hard copy that I brought online. Moreover, I wanted to share with you that back in February, we brought many partners together, many partners that had worked with us in chronic disease prevention for many years. So there were a few people here in the room that were at P21, and I want to thank Dr. Revelo, Hattie, Deborah, Mary, for coming. Because our aim was for each goal area that I just described to really focus, well, what does that mean exactly? Because this plan is enormous and very comprehensive. So for healthy communities, we thought, well, let's try to engage people and come together for collective impact. For goal 2, it was let's find a way to really get health system partners like yourself interested in investing in prevention with the evidence. Number 3, it was let's make sure we leverage the opportunity for health information exchange, meaningful use out of the Patient Protection and Affordable Care Act. And then finally 4 was can we focus together at looking at wellness trusts. So what did the department come back with after hearing from our stakeholders what they thought was important? Well, for goal 1, the California Department of Public Health will be working with partners to create a compendium of best practices for how we can think about impacting general plan guidance with health impacts. And the Governor's Office of Planning and Research will be working with some of that integration. Goal 2 is really the area for this group. And I share that with you because I'm really looking to this group and this discussion from this meeting to inform the first bullet there, which is I will convene a statewide work group to increase the integration of public health and the healthcare sector. And the real question is, as this group commits to something, would it be something a broader group could learn about and pilot larger? It's to be determined. We also are going to hire within the year a health economist at the state of California to perform many new return on investment analyses on our prevention work. So that individual will be available. And then there is a health reform coordinator that's been brought on board at the state, a colleague of mine. She's going to be wonderful to just keep tabs of all the types of opportunities out of that federal legislation, or that law, I should say. Goal 3 includes an online toolkit we should probably have out in about 6 months or so. Because as people see and choose an objective to frame or to work on in the wellness plan, and they see a state number, they may say, well, that's interesting that the state's at, like for instance, the objective I raised, 91%, but what's the metric in San Joaquin? We're going to create direction so that everybody knows where their county level data is if it exists. We also want to share with you that the California Department of Public Health has a lot of requirements for providers to report certain types of data, and that there is one place now, this Health Information Exchange Gateway, where providers can register, and that's the one portal or door for all reporting requirements to the state. If you go through there, your electronic health record will be able to exchange required and mandatory data through that process. So if you've not visited that site, you may want to look at it. And then finally, I want you to know that just this week, the department has had an open data portal that has launched. This data portal, and what I'll do is I'll send you, Hattie, an announcement about that. Let me tell you about the data on that data portal very quickly. We have a data portal where you can go online and see what the poverty rate is at the census tract level on a GIS map. We have a map that tells you what the birth weight of kids in different census tract levels are in your community. We have the age of the mother giving birth. We have the asthma rates in emergency room visits by jurisdiction now online. And the information was available online before, but this information is going to come a lot easier, queryable. There are a few other elements, but I thought I'd share that with you because it's very exciting, the kinds of information we're adding to this. The final commitment is that we've agreed to support the Secretary in the California State Innovation Model Grant if we are awarded, and I'm going to tell you a little bit about that. Again, we're going to continue to coordinate, communicate, work with all of you. Let me tell you a little bit about this last opportunity. How many of you have heard of the Center for Medicare and Medicaid Innovation, State Innovation Model Grants? Okay, so when the Patient Protection and Affordable Care Act was passed, there were multiple areas of funding, including to this entity, the Center for Medicare and Medicaid Innovations, billions of dollars, because the thought was we need to do better in some of our expenditures at the federal level, including the way we do Medicaid and Medicare. So the state of California back a year ago received a design grant and used the Let's Get Healthy California frame for something called the California State Healthcare Innovation Plan. We have just submitted last month an application to receive $100 million over 4 years to implement this plan. Let me tell you about the plan because we'll know in October if the funding comes to California. There is a graphic online that shares this well. And what it does is it shows you the triple aim, as I've described before, at the top, that top bar, as sort of the context for our plan. But the initiatives that they're proposing would be these 4. We would do more in California on maternity care to prevent premature elective C-sections, for instance. Number 2, health homes for complex patients. Obviously, we understand here that people with chronic disease need extra care to make sure they stay well, and this would allow for funding to go out and support people that have health homes for complex patients. Some innovative models there. There'd be a palliative care initiative to look at ways we can make sure that people who want to have end-of-life decisions apart from the hospital are supported in that choice. And then finally, accountable care communities. Now, in the accountable care community section, we would receive dollars that would go out and support requests for proposal, most likely, to support 3 jurisdictions doing the work. Number 1, the jurisdiction would have to have, it's competitive, but they would have to really demonstrate that they're ready to hit the ground running and that they can almost ensure that they will see demonstrated savings, with savings going back to the partnership if savings are achieved. That will be something that will come out shortly after we know if we've received the funding, and the agency secretary will make the choice there. The other thing I wanted to share with you is that those initiatives are being framed on building blocks or a foundation, and let me just go through those quickly. The first would be workforce. For all this talk about prevention in primary care, do we have the workforce in place to do that? So OSHPD, the state group responsible for looking at our workforce, would take up that look, and they're planning to focus on community health workers. Then health information exchange would be another building block. Are we doing and making most useful the exchange of data in state government, enabling authorities to do that? Cost and quality reporting system. Are we doing the most with the state data that we have to make our progress across the board transparent? Public reporting, again, to do that transparency back to the public. And then finally, a payment reform innovation incubator. The plan is online. You can read the multiple page plan. The visual I gave you is also available because sometimes it's easier to understand the visual than read all the narrative. That's my presentation. I'm happy to take any questions in this last 5 minutes.
I think we'll probably hold those until Deborah is done with her presentation. And while we do the transition of speakers, I'd just like to say that one, the Right Care Initiative goals for control of blood pressure, lipids, and blood sugar, getting to the national 90th percentile across all health systems, is in the federally designated, now California designated wellness plan, and that this community will have an opportunity to compete to be one of the 3 selected communities that would be called an accountable community for health. And that would be something that we'd have to collaborate across not only the Right Care Initiative, but also the Healthy Sacramento Coalition. And with that, Jose will introduce Deborah. Okay.
I would like to recognize the immediate past speaker. That was a fine presentation.
Jessica had a lot that she's going to be presenting to us, and this is very exciting. And we can invite her back, if you don't mind, Jessica, because I know there's more, and I know there's a lot of questions, and we just wanted to move on with the program because we have a lot to talk about. So again, I'm really thrilled, and I won't take too much of your time to introduce Deborah O'Ken. And I've known Deborah even longer than I've known Jessica, believe it or not. Deborah and I have worked together, and Deborah was my boss at one time. Actually, she still is in a lot of ways. But Deborah is very well known to everybody, so I won't go with, you can see her bio as well in your packet. But Deborah has great experience working with the community and doing a lot of projects, and she's won a lot of awards, and she's going to be talking to us about clinic to community prevention, which is really a key piece of a lot of the discussion that we've had recently here, and again, that we talked about earlier. And again, Deborah is part of the Healthy Sacramento Coalition, doing a lot of great work. And we have the clinical collaborative, I call it the clinical collaborative committee that many of you are here representing. That's such a key piece to the things that we're trying to do with the Healthy Sacramento Coalition. So I'm going to turn it back over to Deborah, and she's going to talk to us about this very critical bridging of the clinic and the community.
I love the fact that he says I'm his boss too. I haven't heard that before. So thank you for letting me be here today and to chat a little bit about community prevention. I was at the P21 conference that Dr. Nunez had referenced, and I believe it was Diana Dooley who stood up and said finally that prevention and community prevention is no longer the Rodney Dangerfield of the healthcare community. Prevention and community prevention is finally getting some respect. So I'm happy to kind of talk to you about what I see as kind of this, how we're defining the third sort of triangle of population-based healthcare and how we address the social determinants of health and how we really integrate what we're hearing so much more about now, the social determinants of health, about that health happens where people live, work, play, pray, shop, learn. Health and health outcome is so much more than what happens in the clinic, although all of these pieces kind of need to come together. So as Jose has said, I've known him for over 25 years. A little personal story I shared with a few of you. I have a personal confession. I have a little bit of Porter's disease, and my husband was telling me I needed to clean out a file cabinet in our garage. In that file cabinet, I pulled out my calendar from 1990, and I looked through that calendar, and I had several appointment meetings with Dr. Arevalo. He was part of our early work with the Hypertension Council. So here we are again. I told him, look, we're not going to be doing this work for another 30 years, so we got to make something happen now. We have to work really hard to connect the dots. So I'm going to talk a little bit about this IOM framework, which I know many of you have heard about the drivers of health, kind of the opportunities that are around us. I think many of those opportunities we've talked about over the your sessions, and just kind of the environment that we're working in, and then talk a little bit about some population-based health initiatives that are going on here in our community. First, a little bit about the Health Education Council. This is our mission statement. The HEC started in 1991. This is our 23rd year of operation. This is our theory of change. We really believe that everyone deserves to live in a healthy community. Our vision is focused around reducing health disparities and making prevention the norm. A lot of our talk and a lot of the words you hear now is about working upstream, and a lot of our work is focusing on the upstream kind of causes of disease, why we are in this state of dealing with chronic conditions. What we started as the Hypertension Council was a 11-year funded project by the federal government. We were a regional program, 8-county regional program. And at that time, 1 in 4 Californians had uncontrolled high blood pressure. It was a multi-sector coalition, and what I love is that we're talking today about multi-sector collaborations, and how we all define what multi-sector means is very different. And so Juanita pointed out that in this poll that we took, that kind of a wide array of who is a sector that really impacts and intersects with health, right? We all define that differently, and I think this is one of the challenges that we have before us, to really understand what our individual definitions are about who are the drivers of health, who needs to be around the table. So we had a multi-sector coalition composed of hospitals, healthcare providers, the police department, education, the migrant farm organizations, etc. We implemented provider education and outreach to implement the 4th Joint National Commission Hypertension Guidelines. At that time, you could not go to the pharmacy and get your blood pressure checked. And so we started blood pressure screening sites, and there was a lot of drama around that, because should lay people be taking blood pressures, and are they going to be treating people? And so we came up with protocols. But a big part of our program was about community engagement and education through grocery stores, migrant camps, senior centers, churches, et cetera, et cetera. We also formed three lay ethnic specific task forces around African Americans, Asian Pacific Islanders, and Latinos to look at the disproportion of burden of hypertension or the inequities in adherence and control. So I was thrilled at last month's session when Dr. Winston Wong was talking about Kaiser's intense effort to focus on African Americans and high blood pressure control. So over the years, this stuff has been around for a long time. We created the Pharmacist's Guide to Prescription Refill Reminder Systems, and James and I have had conversations about the critical and important role of community pharmacists in this continuum and as an essential partner. The blood pressure measurement screening guide was how do you set up a screening site in your community. The Health Education Council, we operate a number of different programs. I'm going to be talking a little bit about our Health Eating Active Living Zone in a minute. We do a lot of work around obesity prevention. I think you all know what the 2 most preventable causes of death continue to be. Number 1 is still tobacco, and the second is poor nutrition and lack of physical activity. So some of our programs that we're operating at this point. So I'm sure many of you have seen this. I was actually Mike Strong, who I think comes to these meetings periodically from Novo Nordisk, sent me this. We were having this conversation about the drivers of health. And so he sent this to me, and he said, this is from 1993, right? That shows that healthcare, in terms of health outcome and health impact, 10% of that relates to healthcare, right? What happens in healthcare delivery? The rest of the drivers relate to the environment, environmental influences, genetics, and behavior. And this is kind of a more recent diagram that some of you have probably seen about the drivers of health. So you see that 10% of the green wheel there is 10% of the driver. The bigger drivers are personal behaviors, family history and genetics, and environmental and social factors, all kind of working together. when I look at social determinants of health, I really look at this 20% and the 60%, the environmental and social factors interacting with how people are the most easy to make healthy choices in their communities, which are highly influenced by highly influence the personal behaviors and choices you can make, followed by family history and genetics. So really there's 90% on this end of the health continuum and 10%. And yet I think what we also know is that 90% of the dollars that we spend on healthcare go into that green box, and 10% are directed at the 90%. So clearly I think, all of us are talking a lot about how do we change that. A lot of discussion about innovative partnerships and relationships really focuses on this for me. Other studies, that United States is one of the wealthiest nations in the world, but it's not the healthiest. I think out of 16 countries we rank on the bottom. We spend far more than any other country, but we're not seeing the kinds of health outcomes. There are many opportunities, I think, before us, and I'm so happy I don't have to go into any deep level of detail in the California Wellness Plan, so thank you for doing that. So at the state level, there's a lot of things happening. The National Prevention Strategy, we know that at the federal level, all of the federal agencies are working together to look at what is health, the intersection, in of course, the Affordable Care Act. So thank you for explaining the California Wellness Plan. We each have a homework assignment to read the entire plan, telephone book. The National Prevention Strategy, this is the federal kind of diagram, which I think mirrors a lot the California strategy that really shows all of the interactions of health and the various factors that impact health. Clearly, all of you are living and breathing and implementing the ACA. There's accountable care organizations, accountable care communities, and a whole lot of new partnerships that are happening, I think, across this continuum between healthcare and health, community prevention, public health, transportation, housing, economic development, education. So there's just a lot of new partnerships, I think, that are presenting tremendous opportunities. We know that we've heard a lot about the triple aim, and know that achieving the triple aim is going to require new partnerships. This was, I heard this from Jared Feely from the Trust for America's Health. And as I mentioned, I think what we defined as multi-sectoral collaboration and partners and who's around that table can be a long list based on where you sit. So again, these drivers of health. I think many of the issues that health has been interested in and that the Health Education Council has been interested in really are trying to speak to the drivers of health. And again, working on the environmental and social factors and the interaction between personal behaviors. So it's been mentioned a couple of times that the Health Education Council has been involved with the Healthy Sacramento Coalition since it started several years ago. It is funded through largely funded through the federal government Community Transformation Grant Initiative. They have just applied for new funding as responding to one of 6 federal initiatives that have been issued by the Centers for Disease Control to continue our work. They also operate the Sacramento Region Healthcare Partnership and have investment in the Right Care Initiative. So I feel like there's a lot of partners in this table already who are working across this continuum that we call health, and I know that Diane Littlefield can explain a lot more in more detail about Sierra's kind of commitment to addressing community health and health in its broadest term. So the Healthy Sacramento Coalition really is focusing on 15 priority zip codes in Sacramento County. It is taking a kind of a multi-sector, very place-based approach to health. It is composed of a leadership team, a steering committee, and several work groups. Those work groups have changed over time as the coalition has developed and matured. Right now, there is a tobacco work group, a healthy eating, active living work group, and a clinic to community prevention work group, which I co-chair with Dr. Arevalo. And as is mentioned, many of the folks who are on that committee are here today, and we're really trying to noodle through, how do we connect the dots here? What can we do with all these pieces that Sierra Health is invested in, but also a lot of great work that's going on in the community to really create these strong relationships, to do something in this community that makes a difference. Right now, we're looking at focusing on the role of community health workers. They're called the Capital Health Network under Jim Ellsworth leadership is really looking at where do patient navigators fit into that, what about care coordinators, how do community health leaders operate in the community, and so that's one of the things that our work group has been focusing on. Other things going on around Sacramento, this Design for Active Sacramento. Some of you have probably heard of this group. They're a multi-sector partnership with the county health officer, Dr. Olivia Curserier. It's composed of planners and designers, engineers, public health officials, and medical professionals who have implemented healthy design standards into Sacramento County's planning processes, integrating, but going beyond health and all policies to really look at how does our environment shape the kind of choices we can make for health. The Design for Active Sacramento has really lifted up the importance of parks and community places for folks to be active. Walk Sacramento is a huge partner in this, the Medical Society. And the Health Education Council just collaborated with Design for Active Sacramento to add as part of the permitting process any gas station that sells food, and in low-income communities, this is where a lot of people get their food, have to have a minimum percentage of healthy food that they're offering. This is something new. We're trying to get it implemented as part of a standing regulatory ordinance where any institution or venue, whether it be a gas station or convenience store that sells food, has to have healthy food. We're also trying to work with fast food outlets to make sure that a percentage of their food is healthy. Other things going on in Sacramento are the Building Healthy Communities Initiative. It's a 10-year, $10 million investment in South Sacramento and Oak Park with 10 indicators of health, all kind of working along similar kinds of areas that we're talking about here in this room. And when I talk about opportunities, the kind of the state level opportunity, the national prevention strategy, the role of accountable care organizations and accountable care communities. And I mentioned that there's a lot of work around place-based work. The other opportunity is the hospital community benefits programs. We know that hospitals now are investing in communities, and many of them are taking a different approach to that. But the Healthy Eating Active Living Zone, which the Health Education Council organizes and coordinates, is a investment by the Kaiser Permanente Community Benefits Program. It is a place-based initiative based in South Sacramento around the Mac Road corridor, the Valley High area, of about 13,000 residents. Our goals when we're entering into 3.5 years of the program, the Healthy Eating Active Living Zone was really focused around 4 high-level goals: 2, healthy eating, and 2, active living. And the intention of this is recognizing that poor nutrition and lack of physical activity is the second most preventable cause of death. Our goals were kind of rolled out to really try to saturate this community of 13,000 people, to intervene at multiple different levels with a bunch of different partners. So this is kind of a graphic view of our framework. Our vision is that people eat better and move more as part of their daily lives where they live. This is our map of our zone boundaries. And some of the characteristics of what happened when we went into this community. The Valley High neighborhood had the highest gang violence activity in the county, high concentration of multi-unit housing. For those of you who are from Sacramento, you'll know what we mean when we say the macro quarter. There's high-risk residents in houses surrounding the apartment complex, but very little dialogue between those who live in apartment communities and residents, a mix of low and middle-income families, higher than average fast food outlets, higher consumption of fast food, higher obesity rates, high incidence of infant mortality, and no community center. Lots of parks and places to be active, but underutilization of those. We coalesced a multi-sector, to use that word again, collaborative to address this problem. One of the first things that we did was focus in on the park. The Valley High Park is a community asset and was yet underused. We engaged Walk Sacramento to conduct a walk audit to help us understand why isn't the community using the park. We took out a group of students and residents and just to do a walking tour and to write down things like, are there broken benches? Is the equipment broken? Are the lightings, is the lighting poor? And to do an environmental scan. When we started the walk audit, there was a shooting about 30 feet in front of us. 2 rebel gang members stepped out, and of course our walk audit team ran off and decided that wasn't quite the day to do this walk audit. This walk audit was being conducted at 3 o'clock on a Friday afternoon. So what did we learn? We learned that we could not achieve our higher level goals unless we address safety and violence in that community. So what we focused in on transforming that park and making the neighborhood safe. We expanded our coalition. The police department became a stronger partner. The business community engaged in a big way because the macro business partnership, their biggest worry was vandalism of their local businesses. We increased churches in the area and all of the community-based organizations doing violence prevention work and engaging kids. We redid the walk audit and engaged this group of folks to really focus in on what needed to be done. The city invested in a new traffic signal, and the community had been saying it's not safe to cross the street. The city invested in improving the soccer field and just simple fixes of changing the lights that were burnt out, of leveling around unlevel playing grounds in the park. We trained residents to run walking clubs. We engaged the medical society to do walk with the dog there in the park. The residents who run the walking clubs, they do food demonstrations at the park and pass out free produce to folks who come to the program. So these are some of the transformation things that started happening. Neighbors returned to the park usage increased by 60%. People who live in the community would come up to us and say, I've lived here for 20 years. I didn't know some of these people that live right in my neighborhood or that I'm now walking regularly with. A local church has adopted that park. The community engaged does all the maintenance. We do nutrition education at the park at these communities events. The city has invested and added park amenities. The traffic signal installation, was done in the fall. Violence is reduced, and residents have really taken ownership of the park. This is the beginning, I think, of what we're seeing as community transformation in that neighborhood. What that led to is a sister initiative called Reimagine Mac Road. It's engaging the Rebuilding Together, the LDS Church, the Mac Road Partnership, which is the Business Improvement District, and the Health Education Council. We, in April, mobilized over 1,500 volunteers to install street murals, a street monument, a playground, Rebuilding Together selected 100 houses to fix in the neighborhood. And there's collaboration that started to build St. Andrew's Church into a community gathering center, and that community gathering center will be launched around the 1st of September. The other outgrowth of our Hill Zone work has been around the launch of Summer Night Lights. I mentioned when we went into that community, we knew that we had to deal with safe neighborhoods before we could talk about health at all or increasing your physical activity. So in June, we launched Summer Night Lights together with our partners on the bottom, and every Thursday, Friday, and Saturday night at St. Andrew's Church and throughout the Hill Zone, there are activities that are going on in that neighborhood for families to engage. What we know is, I mentioned that violence has always been a big issue in that neighborhood, so we've been kind of tracking what are our outcomes. Initially, our outcomes is there has not been one homicide in that neighborhood this year. And we're in close connection with the police. And I asked a lieutenant, I said, tell me how this compares to prior years. And he said, honestly, I cannot remember one year where there has not been a homicide in that neighborhood. There has been reduced calls to police. There has been reduced calls to the Business Improvement District for security-related calls. What's exciting to me is we're integrating healthy eating into this approach. So every Thursday, Friday, Saturday night, the Elk Grove Unified School District provides meals for everyone that come. Those are healthy meals. And one of the other nights, one of the young kids said, I want more of those red round things. Can I get some more of those red round things? I really like those. What's he talking about? Oh, you're talking about grapes. You want more grapes. So integrating kind of healthy eating where people live, work in their neighborhood, I think is changing the way people think about being active and about eating healthy. We have people who actually know what a jicama is now. Some folks didn't know what a kiwi is. So I think our approach of integrating education at places that are safe for folks is paying off. Lots of other stuff going on in the community. A lot of faith organizations working to improve health, working upstream, if you will, dealing with the kinds of things that aren't always seen or dealt with in the healthcare setting. Martha Garrity and her great work in health medicine, doing a lot of education work and connecting a lot of these dots on the community side. Warren Barnes Church at Grace Presbyterian, they have a whole Farm to Every Fork initiative. His church folks have been trained to enroll folks in CalFresh, or food stamps as they're traditionally known, but really working out in low-income communities to increase access. The Sierra Health Foundation is launching this initiative to support about a dozen churches to open up their spaces, their church grounds, for physical activity and socialization. We know that's a really important element of social emotional wellness and physical activity in a community. Health Education Council, we work with about 20 different churches to integrate just at their level to say, how can we get your congregation members to be eating healthier and being more active? So these are some examples of the things. We have a lot of recipe books and resources we'd be happy to share with you. I think many of you have gone to a farmer market, know that there are farmers markets in this community. This is a partial list of them. I have a handout, and that farmers markets listed in red are those farmers markets that accept EBT for low-income families, and they also have a cost-sharing program. So if you are low income and if you purchase $5 of produce, you will get another $5 free. There are cooking classes that are conducted in community sites and at grocery stores. We have a series of Cooking Matters classes at local grocery stores. Everyone that comes gets $10 worth of free groceries if they complete the class. I mentioned the Medical Society and the Just Walk, a Walk with the Doc program. There's a calendar that I have copies of. I encourage you to visit their website where you could send folks to walk with the doc. The first time we did it in Valley High Park, after it was cleaned up a bit, we got 50 community folks to come out and walk with the doc. You know, what I know is that in many communities, healthcare providers are highly, highly respected folks in the community. And so just kind of having people show up and then walk with the doc is a great motivator for folks to get active in their own communities. So I invite you to get involved. I was telling Hattie that just in the last week, I've gotten, I don't know, 3 or 4 calls from healthcare providers, physicians mainly. One's 2 surgeons and a hospital intensivist, saying, I have my practice and what I do in the clinical setting is really important. I just want to get involved in the other aspects of health. And so I'm seeing, you know, the Design for Active Sacramento, Edie Sussman, who some of you know, she's like a principal and a big driver. She's a neurosurgeon, and she is front and central in the Design for Active Sacramento movement here. So I think there's a lot of ways that you can get involved in, maybe in your own faith institution and leading a walking group in your neighborhood, in getting involved in some of the great work that those of you in this room are carrying on. So I feel like there's, you know, I wanted to call this Connecting the Dots because I feel like Sacramento County has a lot of dots going on, a lot of great work, a lot of the incremental work that the Red Care Initiative has done. I think we're all working towards the same thing. And I think we need to really, you know, talk seriously about how do we define population health. I define it a little bit different from you or from somebody else working in a different setting. Get around those definitions and really help kind of sort of understand what do we need to do to make Sacramento the healthiest city and county in California and in the country. I think there is tremendous, tremendous readiness to do this work and to come together. And I think Red Care is and you know, working with the Sacramento Coalition and all the other great stuff going on in the community, which is really prime for that. So, thank you.
Thank you.
Thank you, Debbie. That was great, and you've done a lot of great work, and I think it's important for us to kind of collate that and see what we can learn from all of those projects and maybe grow them and make them even bigger with this new opportunity. So we have time now for question and answers, and perhaps Jessica now would be able to, you know, field some questions for her. So this is really the time for you as the participants to really interact. And if you have any ideas, any questions, any concerns of our speakers, this is the time that we want to provide to you to interact and to you know, give us your thoughts.
So as always, I'm like a broken record. I just want to point out that in the national prevention strategy, in our state prevention strategy or wellness plan, and in our documents about Sacramento, we know that it's heart attacks, strokes, and diabetes that we need to focus in those areas. And the primary prevention that Deborah Oda-Kent was just sharing with us is a critical piece of this. But I think it's just so important to recognize that in Sacramento, we have a higher incidence of heart attack and stroke than the rest of the state, and about half of those heart attacks and strokes have a comorbidity with diabetes. There's a lot we can do with healthy eating and the Let's Move campaign to prevent a lot of these events. And with that, I would just encourage your thoughts on how we can collaborate on not only the secondary prevention, which is our normal topic, but also the primary prevention aspects. What would help support the health systems to maybe not see so many heart attacks and strokes?
This is Jessica. I just want to make one update to the open data portal that the department has put out. I failed to let you know that a couple other data points may be of interest to you. The first is that we have a map that shows WIC recipients where they can cash their WIC benefits across the state. That's important because often they have limited transportation and can't be going to places and hoping that their benefits will be taken there. The other thing is that we will have a list of all health facilities. It's there now that exists in California on one map as well. So I think that that's helpful for you all to know. You might want to try and find your health facility on that list. Make sure it's correct. And let me know if there's any problem.
Just want to say that it sounds like a broken record, but everything that we do and that we talk about and everything that we be doing in the community and everything related to this group, and that we need to do it in multilingual, multicultural, and understandable language.
Thank you, that's a really important point.
In thinking about primary prevention and secondary prevention, one of the things that we might keep in mind is that people come in families, and that therefore when you have an identified patient, you probably also have children or grandchildren or nieces and nephews for whom issues of prevention may be particularly relevant if there's been an event and an identified patient in the family. So maybe as we think about those two domains, we can actually think of where they intersect and where the opportunities are to touch many individuals related to a specific event and secondary prevention.
I love that concept of reaching the whole family, because one of the things that we talked about here last August, we've now been going here for 2 years, but 1 year ago we were talking about not just educating the patients who might have an event, but obviously the culture of the family has everything to do with what the outcome will be. So as we're teaching a patient about the high risk, we need the whole family to cooperate in changing the behaviors and better eating, etc., and to have the family recognize the events, because obviously when somebody's having a heart attack or stroke, they're not the one that can call 911, most likely. Liz Helms, Chronic Care Coalition.
And that's not just the older people in the family, this is the kids too. It's really important because kids have such a huge bearing on watching things for their parents and doing things. I have a couple of question and comment. On the triangle, the 10% healthcare, 20%, and we're looking at 40% behavior. It's been my experience that a lot of the health plans, as we talk to them and we sit at the table with them a lot, don't look at the prevention piece the way that they need to. They're still looking at sick care. They're grappling with data that are hospital information when you're inpatient, not when you're outpatient, and even to record blood pressure and then report that has been a problem, because that's something I personally have been experiencing with the data group that I'm working with. And so how do we all together start to move that discussion away from sick care and acute care really into focusing in prevention And that's even preventing comorbidities of chronic disease. And then the last thing I just wanted to say, because all your presentations were fantastic, on the, when you're doing the night lights, did you work with the neighborhood watch programs too? It looks fantastic.
Hi, Chris Wood from Dignity Health. I wanted to come back to Hector's presentation. Obviously, the prevention piece up front is very important, but I think the community education about the new treatment modalities available, once somebody recognizes they have a stroke or a heart attack, that there's a lot that can be done, but getting to the facility in a timely manner is something that we struggle with, and there's still treatment windows that limit the ability to have a good outcome. And if we can get people educated, you mentioned the FAST campaign, we've tried to partner with the American Heart, American Stroke, and getting the word out. So it's kind of that middle piece of education once they do have high blood pressure, maybe some risk factors, and then recognizing those symptoms very quickly. Just as far as comprehensive stroke care, we want to deliver that, and we are delivering that. But again, we have to get people aware of those symptoms early on.
Thank you. And Mike McCabe with United?
I don't know if I need to.
I think you do need a mic.
And I want to comment on this call. I just apologize, I don't know your name, but you were commenting about health plans. I'm with United Healthcare and I represent the Western region. And I don't know if everybody in the room knows this right now, but Medi-Cal's updated their waiver. And what that means is Medi-Cal is going to CMS saying, what do we need to do to transform our delivery system? And Dr. Nunez is working on a SIM grant. Many other states have gone to their waiver and mandated the things around nutritional counseling, obesity, that education is a part of the healthcare cost. And that allows payers to then reimburse the providers for that cost. States like New Mexico, Washington, New York, Kansas, a lot of states are doing this. Highly recommend all of the organizations here put a voice in the Medi-Cal to update that waiver to do that. That way, clinics, CHRs, which are the community health workers under reservations, can afford to keep those community health workers and not only have them on staff, but then get paid for that service. I've had dialogue, I'll continue to have dialogue with others and other parties, but this is a great opportunity for California to make that recommendation and move this forward.
Thank you, Mike. Yeah, Medi-Cal is typically with us. Thank you. We have a new participant from Medi-Cal, Julie.
Hi, my name is Julia Logan. I'm with the Department of Healthcare Services. And just to your point, there is a first stakeholder engagement about the 1115 waiver on September 11th. So you can look at the DHCS website and there'll be more information. So, and you're exactly right, there's so many things going into that waiver that we're going to need all the help we can get with input and advice. So.
Can you say anything yet about the Medi-Cal blood pressure campaign?
Well, we are starting a hypertension quality improvement project. And I was going to talk to you actually because one of the things we wanted to incorporate was home blood pressure monitoring, but we're not sure the whole payment aspect is a quandary for us. So yes, it will be a quality improvement project around hypertension starting, I believe, at the end of 2014, and it'll be focused on improving hypertension control to the national 90th percentile, which is 70%. So that's for all the managed care plans.
Thank you. That's really huge news for Medi-Cal to be taking on blood pressure. We've been working on Medi-Cal for a few years now to get them to collaborate on that critically important goal. We had a speaker earlier this year that said, if we can get blood pressure under control, we can reduce strokes by half. So let's see.
I can't pass up the opportunity to chime in as well. One of the impeding factors in community health centers from integrating further into.
You get closer to the mic, please.
Sure. One of the impeding factors for community health centers in connecting deeper into the community and addressing prevention and prevention services has been our ability to pay for those community health workers, to include those costs in the costs of our projects as we report them to the federal government. This 1115 waiver that Mr. McCabe mentioned and Dr. Bates mentioned, is a really important stakeholder event, and it will continue, and we need to be clear with the state of California that this is how our community health centers are going to connect with the community in a sustainable, long-term way. I really appreciate that support.
Martha Garrity wanted to say something from HealthNet.
I thank everybody for presenting today. I think it was really wonderful to bring this whole program forward in terms of the community outreach piece, because I've been involved in the continuum of the 3 entities that have been involved with this Right Care initiative as well. Having gone through it on a personal perspective for a year with my mom, and all 4 sisters have over 25 years of high-level medical experience, we found the biggest challenge was navigating between the continuum of care. From the time when she was diagnosed to the heart surgery to going back to the primary care, in terms of understanding the process, and this was 4 of us who had a lot of experience in healthcare. So I think that what's really important is really to get to the basics of prevention, the basics of understanding our communities that we're serving. Because had we been, say for example, a family from the Hmong culture who did not understand terminology, who did not understand the process, who could not find literature in their language, we would have been at a huge disservice, and my mother would have died much earlier, not been able to fight within this journey of heart disease. So I think it's understanding the journey and the process and looking at the whole person and the whole family in terms of our approach and developing a system that connects the dots between the health organizations and the community. It's very, very important.
Joan?
Thank you. I would just like to add to what Martha said, and if we're talking about getting to the prospect of increasing our community education, our patient education, our families, I've done this for 37 years at UCD. And,
at UC Davis?
And one of the things that really concerns me is that, again, we cry about the cost of health care, but we concentrate on the treatment because that's where we can get the payment. You don't get much payment for teaching somebody to give themselves an insulin injection if you get paid at all. In moving that forward, I just completed a 2-year grant that I had down with migrant farm laborers down in the Bakersfield, Lost Hills area, appropriately named. And one of the things that I learned from that was that I learned to work with promotores. Now, promotores are women from the community. Some have health education behind them. Others are just good people who want to serve their community. And what concerns me is when we talk about not being able to reach our communities, is do we really know our resources? You don't have to have a PhD to teach someone how to, even give their insulin. We teach it to babysitters, we teach it to grandparents, but we need to look to our resources, our people within these diverse cultures that we have, who are used to this and very much more accepted into the home than I was as a professional. And when I worked on an Indian reservation, I wasn't even welcome in the home. I had to work with the health aides, health educators. So I would like to just put that in your minds as you go back to your organizations, that we really have a lot of resources out there that are untapped and that are getting fairly fed up with it and not volunteering anymore. So we need to do this, and it will work.
behind you, Gail Simon.
In that regard, I'd just like to make a comment that there are numerous resources in communities. There are community health workers, there are promotores. There's also medical assistants who are deeply embedded in the communities. A policy issue that this group may want to keep track of is the regulatory and other processes that will start to favor or advantage certain of those community workers above others. We've just been working at UC Davis on some care coordination work, the technology-enabled work, and we've developed protocols that euphemistically talk about community workers instead of identifying any particular title or skill set, because you're absolutely right, there's a variety of tasks and a variety of individuals that bring great strengths to those tasks. But there is a policy and context within which we will find ourselves operating and constrained potentially.
Thank you, Jim. I wonder.
Can I make a few comments?
I can see you there.
Yeah.
Gil.
Okay. So I'll be a broken record also and talk about how all this translates to Medi-Cal, since that's the only sector that I have any competence in. First of all, the Medi-Cal provider network is not integrated at all, as are the Dignity and the Sutters and the Kaisers and the VAs. We're very fragmented. Most of the delivery is provided by individual mom and pop shops in strip malls who are aging rapidly and soon will be extinct, and with very little knowledge of technology and very little ability to partner with anybody, because there are too many to partner with. So integrated care, coordinating care, and partnering care is going to be a huge challenge for the healthcare system and the Medi-Cal provider network. I don't know how that's going to happen, quite frankly. My point number two, and I have so many things I want to say, but we're running out of time. If the behavior is the major driver of healthcare costs, 40%, then changing the behavior has got to be the #1 priority. And the state of the art for changing behavior is through the motivational interview that Martha talks about, and that we try basically unsuccessfully to get our providers to accept. And I wonder if the older providers have been taught a different system of interview, and hard to change older providers to adapt to this new method of interview. Some medical schools throughout the country, 2 or 3 as I know of, are teaching this process to medical students. I wonder if any of the California schools are teaching the motivational process.
Dean Joseph, could you say something about that?
First of all, I'm a dean for research in the School of Nursing, not in the School of Medicine, but I will say within our School of Nursing there's a lot of interest in the acquisition of these skills. We do not at this point teach pre-licensure nurses. We teach master's nurses and PhD, but I think there's a deep commitment. My other nursing colleagues are probably very aware of and involved in teaching motivational interviewing work.
I wonder if Don Forrester could say anything about how they use that, or how you use that at Kaiser.
I would agree with what you said about motivational interviewing. It's evolved. I think, I used it personally the first thing you need to do is give people the correct information and then align it with what they're trying to achieve personally. It's a very patient-centered sort of approach, understanding the family setting that they're in. So I think there's a lot being written about it now. I think it's something we've wrestled with in medicine, and I know nursing has for a number of years. So I think it's successful, having done it for the last 3 or 4 years pretty heavily before I sort of stepped down from Kaiser and I'm in my Encore career. I gave up predicting who's going to do what, given the information I gave them. I was pretty sure that the 2,000 or so patients I had taken care of for 30 years, I could predict what was going to happen, but I was wrong as much as I was right. Some of the people in my practice who we almost had security in the room when they came in to see you were some of the ones that adapted quickly, whereas the other more educated people didn't. So I saw my responsibility basically as trying to meet the patient and help them make the right decision, but also provide them with the best information. Because I got out of UC Davis family medicine program in 1978, and we have learned a few things since then. So even if I was taught something then or in medical school, it's more about keeping up with the amount of information that's coming out. I mean, there's 12,000 articles written every year on health and nutrition related to human health, and about 10 or 11,000 articles come out weekly in the medical literature. And as a practicing physician, trying to keep up with the best of that is a real challenge. So I appreciate all the comments, and thanks for inviting me today. It's been very enjoyable.
It's great to have you with us, Joan.
There is a PhD attached to the Department of Family Medicine at UCD who's doing motivational interviewing. And we've had her speak. She's really, really good. So there is,
one of the ideas that came up in this forum a year ago was to really use that motivational interviewing on that education of the high-risk patients and their families, potentially by creating some video materials that the patient and their families could view right before having a motivational interview, so that, as Dawn said, you make sure that they get the accurate information first. And given the time constraints on primary care providers, some shared video resources to relay that information just prior to a motivational interview may be one approach to help spread the knowledge through the community.
But Hattie, from all the talks that I've heard that Martha has sponsored, that's the wrong sequence. The right sequence is to establish an empathic relationship with the patient, and then through, it's the wrong sequence. You don't provide the information without first asking permission to give the information, and you don't do that until you've established an empathic relationship with the patient, all of which are really nursing skills that need to be taught to doctors. It's not so much informing the patient, but guiding the patient to making their own decisions with your help. So all this requires time and patience. My role at my point in my career is adapting all of these wonderful things to the Medi-Cal world that I live in. And so I'm now teaching my providers not the motivational interview, but the motivational conversation. Because that takes only a few minutes to do, instead of 30 minutes to do. So
it isn't meant to replace the relationship between the provider and the patient, but to enhance it.
Yes, but you can't give the information until they accept you as a colleague, as a collaborator, and as a partner with them. Otherwise, you're just talking to the wall.
Hector, did you want to revisit some of the questions that you raised earlier?
Well, I guess there's a lot of different ideas in the room, and I think maybe this is not the right forum to flesh out details about a potential collaborative approach from this discussion. I would like to ask, we'll send an email out to everybody in the room today, and if you're interested in having a follow-up conversation before or after this meeting next time, that would probably be a better, more productive way of getting solid. I think we have a lot of great ideas. We have to start somewhere and start probably pretty small. But I think there's a lot of energy in the room, so I'd like to entertain deeper follow-up conversations. You can also email Janice, and really Janice and Jill are the leads on the tech side, so if you had a lot of interest on the technology side in terms of care coordination, I think Janice, the other kind of community education and patient education and families, I'll be the contact for that, and you'll get an email either for a meeting before this meeting or after this meeting next time. The other thing I'd ask is, the only time I've ever lost one of these clickers, I actually own these, is in a faculty meeting. Students have never stolen. So my faculty colleagues have. And I trust you guys won't take them, but you might forget them. So make sure to leave them out on the table as you leave.
Yeah, thank you. Time check. We've run up against the terminal time for us. I wanted to thank you all for coming and remind you that our next session is going to be September 8th. So it actually is, very quickly in September, just so, again, we meet the second Monday of every month. So hope that you have a pleasant rest of the week, and look forward to seeing you on September 8th.